Hello, everyone. Hello and good evening, and welcome to another NCLEX review with Alexandra. It's a blessing and a pleasure to have you all here. So, today we're going to pick up where we left off, and we're going to be discussing. We had left off on stroke, and then we had some audio issues, and it was so difficult. So, we're just going to pick up where we left off. So, remember, another name for stroke is cerebrovascular accident or CVA. This occurs when there's poor blood flow to the brain and it leads to brain cell death. Okay, so remember that when brain cells do not receive oxygen for more than 10 minutes, those brain cells die, and this is non-reversible. So remember, stroke cannot be reversed. Okay. So there's two major types of stroke you have to know for your exit and for your NCLEX: ischemic and hemorrhagic. So ischemic is because of a blood clot. Hemorrhagic is when a blood vessel bursts open and this causes bleeding into the brain. Okay, so let's look at the pictures again to help us remember. So as we can see, we have on the left, we have ischemic stroke where there is a blood clot causing a blockage, okay? And what has precipitated this is the buildup of fatty plaque in the lining of the artery. So this buildup of fat, remember we talked about, is associated with poor lifestyle choices, right? Poor diet, lack of exercise. Then we have hemorrhagic, where you can see the blood vessel has ruptured and it leads to bleeding. And so the blood is supposed to go up here, right, to go oxygenate brain tissue, but instead it's coming out. And this is going to do two things. One, we're going to have ischemia of the brain tissue over here, like, let's say that this is over here. It would be the brain tissue over here that wouldn't get enough oxygen. So you have that. And two, this bleeding into the brain is going to cause a buildup of pressure, which is going to increase the ICP. Okay? And we learned a couple of classes ago how dangerous that can be. So the signs and symptoms, remember, it depends on the area of the brain, but the common signs and symptoms of stroke are facial drooping, slurred speech, blurry vision, numbness and tingling, and paralysis. Remember, your priority is to get the patient to CT, okay? We want to get the patient to CT as soon as possible so that they can diagnose if the patient is having a stroke and what type of stroke is it. Now, you want to maintain airway patency. So with a stroke, I want you to write this down. You have two priorities with a stroke, and you will see things like this on the NCLEX and your exit. Two priorities for stroke. Number one is time. Okay, number one is time. And then I want you to write time is brain. And after you wrote that down, I want you to let me know, what does that mean? Time is brain. Hello, Mr. Isaac. How are you? Hello. I saw your message earlier, okay? And I'll address it. Hello, everyone. Okay, let me make sure everyone can unmute themselves. Hello? So we just said that with stroke, you have two major priorities. The first priority is time. And then we
Excuse me, Dean. This is not a good medium for me. I tried to put it on my laptop. It didn't work.
Okay. Well, I'll just manage. It's about 1 hour.
Okay, hello?
Yeah.
Okay, you said that the audio is not good?
The audio is good. It's just that I'm not able to.
Oh, to write.
No, I'm not able to use the laptop. Instead, is the phone. Okay, go ahead. I'll manage.
Okay, okay. And
Time
it is
short.
recorded.
Mm,
It is recorded.
okay.
Okay. So, all right. So we said time is brain. What does that mean? How long did we say that brain tissue can survive without oxygen?
If 5,
Some say
no,
4 hours.
no.
Mm-mm.
5 to 7 minutes.
Right. A lot of people say 4 minutes, and some books will say up to 10.
Yeah, sorry. Yeah, some say 4 minutes.
Yeah,
So,
some people say four
mm.
minutes, some people say 10 in the books. So when we say time is brain, what does that mean?
It does mean that the earlier you get
Get them
the
help.
patient help, the better for the patient to survive
Right.
the stroke.
Very, very good. Very good. The earlier the better, because so basically what time is brain means is that the more time that goes, the more brain the person will lose, the more functional brain tissue will die. Okay? So time is brain, which means the number one priority with stroke is time, and we need to get the patient to CT. The American Heart Association recommends to get the patient to CT scan within 20 minutes of coming through the door and having a suspected stroke. Okay? So if you ever hear code gray in the hospital, code gray, they're saying they will. So if you suspect a patient has a stroke and you let your charge nurse or you let the doctor know, they're going to call a code gray. And code gray is to let the people in the CT room to clear a bed, because we need the patient to have a CT scan immediately. If you work in the emergency room and someone comes in with stroke-like symptoms, we want to get them to CT scan within 20 minutes. Okay, so interventions, call code gray. If you're outside of the hospital, you would call 911. Then you're also going to perform something called the NIH stroke scale. Okay, so write that down. NIH stroke scale. That stands for the National Institutes of Health stroke scale. This is a set of assessments that we do. Like, we ask the patient to grab both of our hands and squeeze as hard as they can. We put our hands on their feet. We ask them to lift their feet while we push down, so we can assess if there's any weakness. We assess their speech and things like that. Okay. Number one priority with stroke is time. Time is brain. Number one priority. There's another number one priority. And I know you're like, how is that possible? How is that possible to have two number one priorities? Well, when you think about it, it's true. The other number one priority for stroke is to maintain airway. And I know it seems crazy, but they're both just as important. To maintain the time and get them to CT within 20 minutes, and to maintain airway, because if we don't maintain an airway, they're not going to get any oxygen in their body. The brain won't get any oxygen and they won't make it. The next thing that I want you to know, so write this down. When it comes to stroke and blood pressure, it's very tricky. I want you to write this down exactly as I'm going to say it. Before a stroke, you want the blood pressure normal, right? Before a stroke, you want the blood pressure normal, because high blood pressures lead to stroke. However, after a stroke, you want the blood pressure slightly elevated. And this goes against everything we've learned in nursing school. But it's the truth. And there's one exception, and we're going to talk about it, but you have to, what I'm saying right now, you must memorize for your exit and for your NCLEX. So let's backtrack. Before a stroke, you want the blood pressure normal, right? So before someone has a stroke, or if someone has not had a stroke, you want the blood pressure normal, because we know that high blood pressures lead to stroke. However, after someone has had a stroke, we want the blood pressure to be elevated, because it will help the brain in the healing process. It will bring more oxygenated blood to the brain. It will help it to recover. This is what we call permissive hypertension. You're going to permit hypertension after a stroke because it helps in the healing process. Now, there is one
Excuse me, what did you call that again? Permissive
hypertension, yes. Okay. Now, let's say that one more time, because I really want you guys to understand this. This is a core foundation of nursing. So, before a stroke, you want the blood pressure normal.
Normal.
Because you know that a high blood pressure could lead to stroke, right?
Yes.
For example, it could lead to the hemorrhagic stroke, where a blood vessel would burst open from those high blood pressures. Now, after a stroke, you want the blood pressure to be slightly elevated, because it will help the brain get more oxygen, more blood flow, to help the brain heal. This is what we call permissive hypertension. Usually, and the doctor will have the protocol. Maybe they will want the blood pressure to remain at 150 over 100 and up. And maybe they want it to be as high as it can be, as long as it's below 180. So the doctor will tell you that in their orders and communication. Now, there's one exception where you don't want the blood pressure to be high, and that's if the patient receives TPA. Okay, so the one exception where you do not want permissive hypertension is if the patient receives TPA. Okay, so then under that, I want you to write, if the patient receives TPA and the blood pressure is too high, the patient can die from a brain bleed. So we're going to say the whole scenario one more time to lock it in. Before a stroke, you want the blood pressure normal, because you know high blood pressures lead to stroke. After a stroke, you want it slightly high, because you want good blood flow to the brain to help in the healing process. This is called permissive hypertension. The only exception after a stroke where you don't want the blood pressure high is if
TPA was given.
TPA. Beautiful. And we're going to learn why, because TPA is like a super clot buster. Imagine TPA like Coumadin times 100. So it's going to make the blood very thin. And if the blood pressure is too high after TPA, the blood vessel will burst open and the patient will bleed blood very easily into the brain cavity. Okay, so next up, in the stroke patient, we want to prevent aspiration. Remember, write this down. Stroke will impair the gag reflex. That's why your second number one priority was airway. We want to prevent aspirations, so be prepared to suction as needed. You can put the patient in semi-Fowlers. You can place them on their side. Okay. Monitor level of consciousness, speech, and strength on both sides. Also, you can monitor gag reflex, okay? Yes, Miss Chantal, go ahead, my dear. You're unmuted. Okay. Yes, Miss Chantal.
Thank you. That was before when you say there's two priority on when you're having a stroke. I say same thing about seizure because where I'm working at a patient, and I know seizure, you monitor time and airway also. Is that right? 'Cause I
You
don't want to confuse.
you are 100% correct. Excellent. Excellent, excellent. And that kind of thinking is what's going to help you to pass the NCLEX. Wonderful. Very
Thank you,
good.
Miss Alex.
You
Thank
will.
you.
Very good. Yes, Miss Elizabeth. You can
Um,
yourself.
Thank you. Thank you so much for the opportunity, Professor. I just would like you to repeat the statement that you made that you accept the
TPA. That's
yeah
yeah,
that the statement that you gave us, the one that you said we need to know. I was writing it down and then I lost you there for a minute.
Sure.
he said the
Hold on,
okay,
Isaac, please.
okay.
You know Professor Isaac.
Eh,
He's my right-hand man. He's my right-hand man. He's a very good nurse.
I'm sorry.
It's okay. That's all right.
Mhm.
Okay, so after a stroke, you want the blood pressure to be slightly elevated because it will help promote good blood flow to the brain, right? The only reason you don't want, like the one exception after a stroke that you don't want the blood pressure high is if they got TPA because it can lead to bleeding in the brain and the patient can die from that. Hello?
Thank you, Professor. I got it. I was writing, so I missed the bleeding in the brain.
Okay.
I just wanted to complete the statement. Thank you.
You're welcome. And remember, that's one of the leading causes of, you can even look it up. It's one of the leading causes of death in a patient who got TPA is brain bleed. Okay. So other things you're monitoring as a nurse. Remember time, airway, blood pressure, level of consciousness. You're going to use the Glasgow Coma Scale, right? 3 to 15 is normal. Anything 8 and below is coma. Speech, gag reflex, strength on both sides. Keep your patient upright, okay? The semi-foulers, you can put them on their side. You want to protect the airway. Important to know, what is a mini stroke? A mini stroke is what we call a TIA, a transient ischemic attack. What does the word transient mean? Okay, what about the word transport? When you take transportation, do you stay in the same place?
No, you're transiting.
Very good. So if you transport from one place to another with transportation, you don't stay in the same spot, right? What about when you transform something? Does it stay the same?
No,
No. So the word trans is like change or different, okay? So transient, does the symptom stay or no?
no, it's ongoing.
Right, they leave, right? So a transient ischemic attack, the symptoms came and went. So a TIA is a mini stroke. The symptoms were there of a stroke, however, they did not persist. They did not last. Make sure you know that. So for example, if a patient comes to the emergency room and they say, oh, and the wife says, oh, my husband, we were at a restaurant and all of a sudden he had one side of his face drooped down and his speech got slurry. But on the way over here, his speech improved. Is that a stroke you expect or TIA?
Yeah,
TIA. Also important to know, remember opposites attract. So if it's a stroke on the right side of the brain, it causes left-sided paralysis. Stroke on left side of the brain is going to cause right-sided paralysis. Aphasia. Aphasia, what is aphasia? We learned about the difference between dysphagia and dysphasia. So aphasia is the inability to speak. Okay, so we want to provide repetitive directions to help them. Okay, give one simple task at a time. Don't give them like a 5-step process all at once. One step at a time. We're going to get up, put your shoes, put your robe, we're going to get the walker, we're going to go to the dining room, we're going to sit down, and here's your breakfast, okay? Repeat the names of objects frequently used. Give them enough time to communicate. You can use a picture board, okay, or a communication board. So medications to know: TPA. TPA is a super clot buster, and is given to patients that meet all the criteria after having an ischemic stroke. So we just said that TPA is a super clot buster. So can you give it to a patient with hemorrhagic stroke?
No.
Very good. Tell me why.
I don't have everything, but at least hemorrhage is like the person is still bleeding.
Very good. So a hemorrhagic stroke, the person is already bleeding out, correct?
Yeah.
So if we give them a super clot buster,
the person is going to bleed more and die.
Exactly. Very good. So make sure you know for your exit and for your NCLEX, TPA is only for ischemic stroke. Okay. We also cannot, so make sure you memorize what I just highlighted on the page. So go ahead and write that down, and then we're going to talk about it. Okay, so for TPA, do not give to a patient with hemorrhagic stroke, someone who recently had surgery, or is on blood thinners. Patients who get TPA cannot get IM or sub-Q injections because they will bleed very easily. So what we will do is we will maybe insert like a central line so that if we need to give medications, we can give them IV. And if we need to draw blood, we can get it from the central line. Because once they get TPA, they're very vulnerable to bleeding. So we don't want to poke them because they'll bleed a lot. Okay? Also, there's a time limit. So they have 3 hours from the start of the symptoms to receive TPA. So there's a 3-hour window to receive TPA from the start of symptoms. Please memorize these things for your exam. All right, next we're going to move on to seizures. Seizures
Excuse me, Professor.
Mm-hmm.
When it comes to ischemic and hemorrhagic, So can you repeat the issue of medication, talking about TPA, the clock buster?
Sure.
So it's not given to hemorrhagic, so it can be given to ischemic?
Yes, absolutely.
Okay.
And so if we were going to look at, let's look at this picture one more time. Hold on. If we were going to look at this picture for ischemic stroke, TPA dissolve this blood clot. Okay, it would dissolve it. All right. Okay, so now let's go to seizures. So seizures is defined as an abnormal and excessive electrical activity in the brain. When someone has chronic seizures, we call that epilepsy. That client should wear a medic alert bracelet. And when they're in your care as a nurse, you want to place them on what we call seizure precautions, which we're going to learn about. Okay, so I want you to memorize 3 anti-seizure or anti-epileptic medications. Phenytoin, which is Dilantin, carbamazepine, which is Tegretol, and levetiracetam, which is Keppra. So please memorize those 3 medications as your major anti-seizure meds. Hi, Miss Bicola. You can unmute yourself. I don't know why it does that, why it mutes people.
Thank you, Professor.
You're welcome. All right, so make sure you memorize those medications. Okay, and remember this is recorded. So there are some things that if I talk about a medication specifically, I really believe you have more than a 50% chance of seeing it on your exam. Okay? So I want you to memorize these facts about phenytoin. Okay? So phenytoin, you have to memorize the therapeutic range. Okay? Can somebody say phen?
They don't give us, how is a new thing now, Professor, that you get all these labs?
I know. And there's
Not in this exam, right?
in the exit.
Yeah.
Well, one thing that might happen, and this is a maybe, on your exit and on the NCLEX, sometimes when they give you a lab, sometimes they give you the range. Sometimes. However, sometimes they don't. So
Okay.
I think it's better to be on the safe side.
Okay.
Can somebody say phen
Phen,
and then say 10?
10.
Phen, 10.
10 to 20, right?
Yes, so that's how you can remember that phenytoin, the normal level is 10 to 20. Just think phen 10, and then you're like, okay, 10 to 20. Phen 10 is 10 to 20. That's the normal range in the blood, okay? If you give it IV, give it slowly to avoid cardiac effects, okay? That's another favorite on exams. In young children, you want them, when they take it orally, you want them to make sure they brush their teeth and floss regularly because it can cause issues with their gums called gingival hyperplasia, and it causes the gums to be tender, so they should brush and floss their teeth regularly. Okay? So next up is a picture of seizure precautions. So seizure precautions is implemented for anyone at risk for seizures, okay? So first of all, what position is the patient laying in?
Left side.
Very good. And for this, it doesn't matter which side they're on, but they're on their side, right?
Yes.
Yeah.
So we're going to call this side lying position, correct?
Yes.
Yes.
What is another way to describe this? Would you say dorsal recumbent or lateral recumbent?
Lateral.
Lateral.
Beautiful. Lateral recumbent. Remember, anytime you see the word recumbent, it means the part of the body that's touching the mattress. So if we say lateral recumbent, the side, okay? So this patient, are they left lateral recumbent or right lateral recumbent?
Left.
Left,
Left.
left
Beautiful.
lateral recumbent.
Beautiful. But either side is fine. But you want them lateral recumbent or side lying. Can you tell me why?
To prevent aspiration.
Excellent. Because you don't know when they're going to have a seizure, correct?
Correct.
Yeah.
Yes.
So if they're laying on their back, could they choke on their secretions?
Oh, so
Yes.
it can whatever can come out by gravity.
Exactly. So it's better for them to be on their side. What are we using to protect his head?
Pillow.
But to protect his head from what?
From secretion.
No.
From it.
What are we protecting his head from?
From the bed frame.
Beautiful. Excellent. We're protecting it from the headboard, right? Because if he starts having a stroke, what if he starts uncontrollably hitting his head on the headboard? Okay. Then
Yeah.
we have the side rails are
Padded.
padded. Why would we pad the side rails?
So that he
reduce
doesn't fall.
Yes,
to
Protect him from falling.
injury, to reduce injury.
exactly. They're very good. There's two reasons: to reduce injuries and also to help prevent a fall, okay? Just to add some extra support and protection, okay? Now, do you want the bed in the highest position or lowest position?
Lowest.
Lowest.
No.
Good. Why?
To reduce fall in case if it happen.
Very good. Because if a patient
Impact.
falls, would it be worse for them to fall from the lowest possible or the highest possible?
The height was
Highest, right. And remember, when somebody's having a stroke, a seizure, excuse me, when somebody's having a seizure, they lose all control of their muscles. They're not controlling their body at all. So they can fall and really hit their head, okay,
Yeah.
and hurt themselves.
Mhm.
Okay. Now, would you prefer your patient to be wearing loose clothing or tight clothing?
loose.
Loose.
Loose
Very
clothing.
good. Why?
To prevent chokings, prevent
Very good. Very
choking.
good.
Yeah.
Very good. What about like necklace, scarves?
No. No, nothing
Very,
like
very
that.
good. Very good. Now, why would we need oxygen and suction apparatus available?
In case of aspiration, like the lady said.
Beautiful. Beautiful. And now, let's say the patient was having a seizure. Do you want the curtains like drawn to like cover and protect the patient, or do you want the curtains open?
Open.
Drawn.
You,
You want them
you
drawn.
gotta be drawn for privacy.
Exactly.
Everybody should not be seeing what is going on.
Beautiful.
Oh, yeah.
Beautiful, beautiful, beautiful. Excellent. Okay. So now, let's see something. One moment. My computer. Okay, so stroke is very important. Seizure is very important, excuse me. Okay, so now during a seizure, so draw the curtain for privacy. Stay with the patient and call for help. Do not restrain the patient, okay? However, you want to protect them from injury. So it's like, if you don't want to restrain the patient, because if you hold them, they could break their neck.
Yeah.
You
Yeah.
know, however, you want to protect them from injury. So, for example, let's say they're having a seizure and they fell on the floor and they're having a seizure. You don't want to hold them because they can break something or get injured. However, if they're having a seizure and they're about to hit the chair, move the chair. Okay? So this is how you can protect them from injury as much as possible. Okay? Or if they're about to go near the wall where they might hurt their head, if you can, put a pillow against the wall. Okay? Always keep the airway open, but we don't want to put anything in the mouth. So, if need be, we're gonna give like benzodiazepines to this patient, like a diazepam that will help to stop the seizure. So we won't even need to really worry much because we're going to stop the seizure. Okay, but just know that we don't want to put, like back in the day, they used to tell you to put a tongue depressor in so that their tongue doesn't fall back and they choke on their tongue, but we don't do that anymore. Okay, but in worst case scenarios, if we feel that there's too much secretions, we can suction them. You can also turn them on their side if needed so the suctions can drain to the side. If the patient was standing or sitting, you can help them to the floor and protect their head and body, loosen any restrictive clothing, monitor the time and duration of the seizure. So Miss Chantal was correct. Your two priorities for seizure is, well, number one would be airway and then time, okay? Monitor their movements and monitor for any incontinence. So,
Question, Miss Alexandra. I'm sorry. I was trying to raise my hand.
oh, I didn't
Emoji.
see.
Emoji. No, it didn't work for me because my computer acting up. But anyway, why do you protect the patient's head when doing a seizure?
Yes. So during a seizure, the patient has no control over what they're doing and they have these very violent jerking movements. So if they hit their head, they can injure themselves. So we don't want that.
I
Okay.
thought it was for like brain injury.
Yeah, yes, absolutely. It's to protect them from injury. So if somebody's having a
Yeah.
seizure and they fall on the floor and they're starting to having the jerking movements and they're about to hit the wall, right? Try to put a pillow against the wall, or if their head is about to hit the wall or the chair, move the chair. It's just to protect them from further damage. Okay.
Okay.
Mm-hmm.
Professor, can I just add on that?
Uh-huh.
I have seen some people with seizure diagnosis have a particular hat, like a cap, to
Mm-hmm.
protect their head.
Now that is helpful.
I don't know why they do that, but they said it was for seizure precautions, so that it might be this case was very severe in terms of when they have the seizure. It's so severe
Second
in
one.
such a way that they hit their head very badly. So I think they ordered this patient a hat, a cap, like a helmet, so that the patient can be having that on at all time, because he usually had seizure very frequently.
Oh, wow.
Miss
Yeah.
Alexandra, my son usually has seizure, but he has the jerking one, like the severe one. So usually I protect his head because I thought it was like for brain injury. So all that time I was doing it wrong. So I'm like, okay, I don't want him to have brain injury. So I didn't know.
No, oh, and first of all, and thank you so much, Miss Elizabeth, for sharing that. And thank you, Miss Janet, for being brave and sharing that. And I'm so sorry that you're going through that. I pray that God would heal him. And yes, and you are correct. We protect their head because we don't want them to get any trauma to their head, right? We don't want them to hit a chair or a door and then lose consciousness and have brain bleeds and increased ICP and things, because seizures mean that the neurological system, the neurons are irritated.
Out of your control.
Yeah, they're out of control. Something has irritated them. And the stress that trauma would put on the brain could trigger another seizure. The stress of increased ICP could trigger another seizure. So we don't want to re-trigger and repeat the cycle We want to minimize brain damage. We want to minimize head trauma and protect the brain. So if we were to do 4 simple steps of what to do for a seizure, you would assist the patient to the floor, assess airway, check vitals, and document the event. So I found this in a question from a very good Q bank. It was like put it in order. And I said,
Yes, it comes. I've seen it.
I found it in a very, very good Q bank, and I said, let me show you just in case you ever see it that way in a question. Okay. So, all right. So next we're going to review the neuron anatomy just a little bit so we can learn about what happens when something goes wrong and leads to a disorder called multiple sclerosis. So this is a neuron. The neuron is the basic cell of the nervous system, right? So just like hepatocytes make up the liver, neurons make up the nervous system. Your brain is made of neurons, okay? The spinal cord is neurons. Your nerves are very long neurons bundled together, and it's actually very beautiful the way they look. I'll show you a picture. So the neuron, you have different parts. Okay, you have the dendrites, the soma, and the axon, okay, and the axon terminal. So dendrites are like little antennae that receive information from other neurons. So all the neurons are like connected, and that one axon terminal of one neuron can be connected over here. So the dendrites receive, the axon terminals send out. Okay, so another axon terminal is connected here, and the dendrites receive the information that it's saying. It gets processed in the nucleus. The nucleus is what we call the soma. So anytime you see soma in a word, that means body. Just like somatic response is your body's response. Soma is the cell body of the neuron. Then the signal, the electrical conduction or electrochemical message, gets sent to what we call the axon. The axon is a tail-like projection, and it's going to transmit the signal through the axon terminal. And this is a very, very beautiful process. And so along the axon, you have, very good, you have what we call,
Speed it up.
yes, excellent. We have what we call the myelin sheath, okay? The myelin sheath, and it encapsulates portions of the axon. Where you don't have myelin sheath, it's a gap, and it's called the nodes of Ranvier, okay? Myelin sheath is made up mostly of fat and protein, but fat is the superstar. Fat is a very good insulator. And what the myelin sheath does is it insulates the message so that the message can shoot through to the right place. Without the myelin sheath, the electrical signal would scatter.
Slow down.
Right, it was very good. It would slow down or it would scatter instead of going straight through to where it needs to go. Okay, and let me just show you a couple pictures really quick just to show you how beautiful. I mean, God really outdid himself, okay, with this. It's a very, very beautiful process. Let me just pull up a couple of pictures. We had to teach this to the LPN students in the LPN program, and I loved it. Oh my gosh, wait till you see these pictures. It's really, this is, okay, all right, and then just a couple of pictures I'm going to show you, just tell you a little story, okay? So this is what two neurons look like connected. So you can see the dendrites, you see the cell body or the soma, the nucleus, you see the axon, you see it's encapsulated segmental, it's like segmentally encapsulated with the axons. You see the nodes of Ranvier, which are like the bare axon, and you see the terminal axon of the first neuron is connected to the dendrites of the second. And you can see how many dendrites there are. And so you can have millions, like you can have hundreds of connections. Okay. So here's another picture just to show you how connected. It's a whole branch, a whole community. Okay. Then here's another picture. Oh, I don't want it to be blurry. I hope it won't. Let me show you, because this is important. If you could zoom in, like, let me show you this. Hold on, let me just do this one picture. Hold on, let me show you. Do you see right here the square that says synapse?
Mm-hmm.
So this is where the axon terminal from one neuron meets like the cell body or the dendrite of another neuron. So this is it zoomed up, okay? So what you see in the square here is what you're seeing zoomed up. So this is what we call the synapse. This controls so many processes that keep you alive. Okay, so from the axon terminal of the first neuron, you can have chemicals like dopamine, okay, like serotonin, okay, that will leave the first neuron. And as you could see, they'll enter the space, which is called the synaptic cleft. And it will leave the synaptic cleft and enter into the dendrite of the other neuron. So that's how it communicates. It can communicate through electrical conduction, or it can communicate through chemicals. So processes like this are what control happiness. Imbalances in these chemicals are what lead to depression, schizophrenia, and a number of things. So these chemicals are what we call neurotransmitters, because they are used by neurons to transmit messages and cause actions. Okay. And so this is very amazing. So now let's go back to what we were talking about, myelin sheath. It's important. Without it, the message that it's trying to send, whether it be electrical or chemical or electrochemical, without the myelin sheath, it would get scattered and not really go to where it needs to go to. Let's see what happens when there's a problem. So we see the healthy neuron here with the nice myelin sheath. But in this picture, what happened in the second picture?
The myelin sheet is disappearing. It's loosening.
Good, very good. It's like degraded, right?
Mm-hmm.
Okay. And guess what? Do you think like an evil bacteria did this?
Yes.
Yeah.
No, well, not that we know of. Do you think like a really horrible virus did this? No. The person's own body did it to themselves. So this is what we call multiple sclerosis. Multiple sclerosis is an autoimmune disease. Let's break it down. Most words in nursing and medicine, you can break it down. What does auto mean?
Something that moves automatically.
Close.
Something attacking itself.
Very good. Because the word auto means self, right? Like automobile. So mobile, that means to move. Auto is self. So with an automobile, you can move yourself, right? Because remember before the car, where people used to travel through horses, but with an automobile, you didn't need a horse. You could move yourself. So auto means self. So autoimmune, self-immune, the own person's immune system is attacking itself. So let's just say, let's pretend I was your patient. If a bacteria got into my bloodstream, would you be surprised if my immune system attacked it and killed that bacteria? Would you be surprised?
It's
No.
No, because you say that, well, that's what the immune system is there for. And what about a virus? You'd be like, yes, I hope that virus dies because it's not supposed to be in the body. My white blood cells will eat that virus up so quick, right? With an
Yes.
autoimmune disease, the person's own immune system attacks the body like it was a bacteria or a virus, full out attack, and it damages things. And in multiple sclerosis, it's specifically the myelin sheath. It causes damage to the central nervous system. Yes, Mr. Isaac?
Yeah, I say sclerosis. There's a scar. You can
Yes.
see it on the axon.
Yes, very good. And it damages the neuron's ability, or it impairs the neuron's ability to transmit messages, and it wreaks havoc on the central nervous system. Remember when we first started talking about neuro, we said central nervous system is the brain and the spinal cord. Okay, so someone tell me, what is the sclera? If I said like the sclera of the eye, what do I mean?
Scar.
Sclera of the eye. That's the white part of your eye. So when you look in the mirror, the white part of your eye is called the sclera. Okay? So why am I saying that? I want you to think, when you see multiple sclerosis, I want you to think multiple sclera. Because one of the major symptoms of multiple sclerosis is double vision. Okay? Also, it leads to weakness and something called optic neuritis, where their eye hurts. Treatment, there's no cure. However, we can use steroids and plasmapheresis. Plasmapheresis is almost like a cleaning of the blood. Okay? So, they can use steroids. I also want you to know that there are steroid eye drops. So if the patient has like a blurry vision, double vision, the eye drops will help the eyesight to recover within weeks, a few weeks. Make sure you know that most autoimmune disorders have remissions and exacerbations. So you want to provide for periods of activity and rest. Also, you want to provide an eye patch for double vision. Okay. So, hold on one second. Let's see. All right. So, I know that we're getting through neuro a little slow, but we're going to get through it, I promise, okay? So, I want you to take your time and study what we've done, because when we come back next week, we're going to do questions on stroke and multiple sclerosis. Then we're going to get into Parkinson's disease, myasthenia gravis, and Guillain-Barré. So make sure you've read the neuro chapter in your study guide. A few of you have ordered the book. I've received the shipment and I will be mailing it out this week, okay?
Which book is that, Professor?
The same study guide that we use, some have ordered the print version.
Oh, really?
Yes, it's $75. That's what they charge me to print it. It's $75, and then I'll print it and mail it out.
Okay.
So, but read your chapters. Also, you have the flashcards that you can use, and we'll do questions next class, okay, from 2 different very good cue banks to help you prepare for all of the angles. All right, guys. Thank you so much for allowing me to spend this time with you. I'll see you next week. As usual, I'll send the recording in the morning, and also I'll send you a message before class next week. Thank you so much.
Thank you, Miss Alessandra.
Professor, please respond, because I'm all set. Vacation, tickets, hotel, everything. It can't be in vain. Please respond.
Yes, you can.
Thank you, Prof, so
You're
much for your
welcome.
time. We
Thank
appreciate you
I
a million
appreciate you.
times.
And I love you guys. I appreciate you.
Have a blessed night.
Yeah.
Bye,
We
guys.
love you so much.
Yes,
Bye.
Mr. Isaac, you can come, okay?
All right, thank you.
You're
Thank you.
welcome. All right. God bless you all.
Bye.
Okay.